I would like to thank Vijay and his team for this opportunity. Dr. Dinakar is not here, so I'll be taking his time, and I've added a few slides from his talk. It's a basic one, how to classify GE junction tumors and how to define Siewert's preoperatively in a practical setup. We all know that GE junction tumors arise at the interface between esophagus and stomach, and that complicates the matter a little bit. By definition, any tumor which is arising with the epicenter of 5 centimeters on either side of GE junction is called as GE junction tumor. Epidemiologically, we see that most of the North American and Western areas are dominated by adeno-CAs. Obesity, GERD, Barrett's are the risk factors. In East Asia and Africa, it is the squamous cell carcinoma. South Asia, where we stand, we see a mixed tumor. And the trends are again increasing trend because of the increased awareness. When we look at classification, why do we need a classification at all? It is basically for surgical planning, accurate staging of the disease, better coordination between multidisciplinary teams, which is the norm these days, better insight into tumor biology, and also help track epidemiology. One of the first attempts to classify GE junction tumors was made by the Japanese. Nishi and et al. Described it way back in 1973. They had a little restrictive thing in the sense that they just included around 2 centimeters on either side of the GE junction as GE junction tumors. But they did classify them into 5 different categories. E is basically into esophagus, G into stomach, EG majorly the tumor is onto the esophagus, GE is majorly onto the stomach side, and E is equal to G where the tumor is sitting exactly at the GE junction. But the problem was this was very restrictive, and it was not adopted widely by the world. Next, in 1996, Siewert et al. Classified GE junction tumors into 3 types, and this was basically an anatomic classification based on the location of the tumor epicenter. They divided it into 3 types, type 1, 2, and 3. Type 1 was basically 1 centimeter above the GE junction to 5 centimeter. Type 2 was 1 centimeter above and 2 centimeter below the GE junction, and type 3 was 2 to 5 centimeter onto the stomach end. So the biggest problem in this Siewert classification is how do you identify the GE junction properly. So that was one of the drawbacks. But there were advantages that it did tell that type 1 were basically distal esophagus tumors, type 3 were subcardinal or stomach tumors, and these were type 3 was stomach. The problem came, or the controversies came, when we were dealing with the type 2, because these are true cardiac tumors, and then there is a little bit of controversy as to how you treat them, whether you treat them with as esophagus or gastric cancers. As we just mentioned, it has a few advantages. The advantages are it helps decision making as to whether these tumors are to be treated as esophageal or gastric, and whether what would be the extent of lymphadenectomy, and it also helps in selecting what kind of surgery is to be done. Another thing was it helps standardize nomenclature across disciplines. And it also can be integrated very well with the TNM staging, wherein type 1 and type 2 tumors are staged as esophageal cancers, and type 3 tumors are staged as gastric cancers. It is a widely accepted clinical classification, globally accepted, and is used routinely. The last advantage is that it facilitates research and innovation.